Welcome, everyone. We're doing a focused deep dive today, specifically aimed at surgical board candidates.
That's right, we're zeroing in on skin. Structure, function, aging, the absolute essentials.
Exactly. Stuff you really need to know for exams, but also just for solid surgical practice. We want to distill the core knowledge.
Mm-hmm. Cut through the fluff. We'll look at the basics, how it changes over time, and touch on some genetic conditions relevant to us as surgeons.
Okay, let's kick off with the big picture, skin's functions. It's the largest organ, right?
It is. Makes up, what, about 16% of body weight? It's not just a covering.
Far from it. Protection seems like the main job.
Definitely a primary role.
Yeah.
Protection from, UV light, mechanical stress, chemicals, heat, cold, microorganisms, a lot.
Plus, it's metabolically active. Vitamin D synthesis happens there.
Crucial point. And of course, thermoregulation.
Yeah.
Maintaining core body temperature. Hugely important.
Right. Okay, so structure. Three main layers, generally speaking.
Yep. Epidermis on top, then the dermis, and underneath that, the hypodermis, each with its own set of cells and appendages.
Let's start with the epidermis, the outermost bit. Keratinocytes are the main players.
They are. They form that physical protective barrier,
Yeah.
but you've also got melanocytes in there.
For pigment, UV defense.
Exactly. And Langerhans cells, part of the skin's immune system.
Okay, and Merkel cells.
Merkel cells, too. They're involved in sensation specifically that sustain touch, static pressure feeling.
Got it. Moving down to the dermis then, what's key here?
Well, the big one is fibroblasts. They're the factories producing collagen and elastic fibers.
The structural components.
Right. And the ground substance that fills the space. You'll also find immune cells, macrophages, mast cells.
Mast cells involved in allergic reactions.
That's them. Plus hair follicles, sebaceous glands making sebum.
Icran sweat glands for cooling.
Apricot sweat glands, too, and then all the nerve endings.
Ah, yes, the sensory part. Different receptors for different things.
Loads of them. Free nerve endings for pain, temperature, chemical stimuli. Then specialized ones like Meissner's for light touch, Pacinian for vibration, and deep pressure.
Krauss bulbs for cold, Ruffini endings for sustained pressure and heat. A complex network.
Very much so. And finally, the hypodermis. Mostly fat, right?
Yeah, adipocytes for insulation, energy storage. Some muscle can be down there too.
It's useful to remember where these layers come from embryologically.
Good point. Epidermis is ectoderm.
Correct. Dermis comes from the mesoderm.
But some cells migrate in, don't they?
They do. Melanocytes and Merkel cells actually originate from the neural crest.
Interesting. And Langerhans cells.
They come from mesenchymal precursors, ultimately from the bone marrow.
Okay, let's zoom back into the epidermis histologically. Its thickness varies.
Significantly. Average is maybe 100 micrometers, but full-thickness skin can be much more. Palms and soles are thickest, mainly due to the stratum corneum.
And that journey for a keratinocyte from birth at the bottom to shedding at the top takes about a month.
Roughly, yeah, 28 to 45 days is the typical range.
And the epidermis itself has layers, 5 of them.
That's right. Starting from the outside in. Stratum corneum first. These are dead keratinocytes, basically bags of keratin. It's the main barrier.
And affected by things like topical retinoids, which speed up shedding.
Exactly. Then stratum lucidum, also non-viable cells, mostly found in thick skin.
Then the granulosum.
Stratum granulosum, yes. Marginally viable cells starting to produce keratin granules. This layer actually thickens with tissue expansion.
Interesting. Below that.
Stratum spinosum. These are viable keratinocytes connected by desmosomes, gives them a spiny look under the microscope.
And the deepest layer.
Stratum basal, or stratum germinativum. This is where the new keratinocytes are made through mitosis. You also find the melanocytes and Merkel cells here.
And some skin cancers originate from this basal layer.
Correct. Basal cell carcinoma, for instance.
Okay, let's drop down into the dermis. 2 layers here as well.
Yep. The papillary dermis, which is more superficial, and the deeper reticular dermis.
And like the epidermis, thickness varies.
It does. Thicker on the back, scalp, feet, thinnest on the eyelids.
So the papillary dermis sits right beneath the epidermis.
Right at the base, interdigitating with it. It's relatively thin, maybe 100 micrometers. High in type 3 collagen, less type I.
And less mature elasta.
Right. Mature elastic fibers are generally absent there. Collagenase activity is high.
Okay. And the reticular dermis.
That's the bulk of it. From the papillary layer down to the hypodermis, can be 2,000, 2,500 micrometers thick.
And this is where the main structural collagen is?
Predominantly type I collagen, arranged in large, thick bundles. And here you find mature, band-like lactality fibers.
Let's talk about collagen itself for a second. It's the main building block.
Absolutely. Gives skin its tensile strength, makes up about a third of total body protein.
And the ratio of types matters, doesn't it? Especially in healing.
Hugely. In normal adult skin, the ratio of type I to type 3 collagen is about 4.1.
But that changes in stars.
It does. In immature or hypertrophic scars, it might be closer to 2.1. Keloids, maybe 3.1. Fetal wounds, interestingly, have more type 3, but a 1.3 ratio possibly related to scarless healing.
And collagen synthesis itself is a multi-step process.
Yes, involves amino acid chains forming procollagen, then tropocollagen, which self-assembles into that characteristic triple helix structure.
Okay. And elastin provides the stretch.
Exactly. It's like the skin's rubber band material. Produced by fibroblasts from topoelastin, it polymerizes alongside collagen.
Needs fibrillin for proper formation, right?
Correct. Fibrillin acts sort of like a scaffold. Elastin allows the skin to stretch and then recoil back. We lose elastin as we age.
Which contributes to sagging. And the ground substance fills the gaps.
Yes, it's this amorphous gel, mainly glycosaminoglycans like hyaluronic acid and proteoglycans. It allows for diffusion of nutrients and metabolites.
We should also briefly mention the blood supply and nerves.
Right. There are vascular plexuses supplying the skin and a rich network of cutaneous nerves running through it.
Carrying signals from all those receptors we mentioned earlier, mechanoreceptors, thermoreceptors, nociceptors for pain.
Mostly free nerve endings for pain, yeah.
Okay, shifting gears now to aging skin. What happens histologically?
Quite a few changes. The stratum corneum can become more compact. The dermal-epidermal junction flattens out, which makes the skin more fragile.
Fewer layers of keratinocytes, too.
Yes, the epidermis thins overall. Melanocyte density decreases, meaning less pigment protection, and Langerhans cell numbers drop, affecting immune response.
And in the dermis?
The dermis atrophies, it gets thinner. Fibroblasts get larger, but they divide less. Sensory receptors, like Pacinian and Meissner's corpuscles, decrease in number.
Less sensitive skin. And the fibers.
You see a decrease in elastic fibers contributing to that loss of elasticity. Ground substance actually tends to increase relatively, and the collagen ratio shifts with an increase in type 3 compared to type I.
Now, what about photoaging? Sun damage specifically.
Actinic changes.
Yep.
Clinically, that's your wrinkles, sagging, or laxity, and mottled pigmentation sunspots.
And under the microscope?
The epidermis is often atrophic and flattened. You see something called dermoelastosis, basically, a mess of abnormal, thickened elastic material in the epidermis.
Loss of normal cell organization, too.
Yes, loss of vertical polarity. Often there's a gren zone, a band of normal-looking collagen just beneath the epidermis, separating it from the elastotic material. The basement membrane can be thick and ragged.
Increased ground substance here, too, and the pigmentary changes.
Yep, increased ground substance, that uneven pigment modeling is visible histologically, and paradoxically, you often see an increase in thickened abnormal elastic fibers in photoaging, unlike intrinsic aging.
Okay, so those are the structural changes. What about physiologically? How does aging affect skin function, particularly relevant for surgery?
Several key things decline. Cell replacement slows down, so healing is slower. The injury response is less robust. Barrier function weakens.
Makes sense. What else?
Chemical clearance from the skin decreases. Sensory perception dulls. Immune responsiveness is lower. Think increased risk of infections or skin cancers.
Thermoregulation becomes less efficient too, right?
Yes, and vascular responsiveness diminishes, sweat production goes down, and importantly, vitamin D production decreases as well. All things to consider in older patients.
Definitely. Finally, let's touch on a few specific genetic disorders that impact the skin in surgery. Ehlers-Danlos syndrome.
Right, EDS. It's a connective tissue disorder primarily affecting collagen cross-linking. Key features are hypermobile joints and thin, fragile, hyperextensible skin.
Which means?
Poor wound healing, often leading to hypertrophic or atrophic cigarette paper scars. Patients might also have redundant skin, especially around the eyes, wide nasal bridge, hernias. Surgery is tricky.
Okay. Then there's cutis laxa, different problem.
Yes, cutis laxa or elastolysis is about elastin degeneration. The skin is hypoelastic, it hangs loosely, doesn't spring back, gives a prematurely aged look.
But wound healing is okay?
Generally, yes, wound healing is normal, but they have an increased risk of hernias and sometimes cardiopulmonary or GI issues.
Pseudoxanthoma elasticum, or PXE.
PXE involves calcification and degeneration of elastic fibers. Clinically, you see skin laxity and characteristic yellowish, cobblestone-like plaques, often in flexural areas.
How's the healing?
Wound healing is typically normal, But PXE can have serious ocular manifestations like angioid streaks and cardiovascular problems due to vessel calcification.
Then the premature aging syndromes, progeria.
Hutchinson-Gilford progeria syndrome, very rare. Patients have profound growth retardation, skin laxity, loss of subcutaneous fat, which contributes to that aged appearance.
And healing issues.
Yes, often for wound healing. They also have other features like baldness, prominent ears, micrognathia, and sadly, premature death, often due to cardiovascular issues.
And Werner's syndrome, sometimes called adult progeria.
Also rare. Causes premature aging features appearing later in adolescence or early adulthood. They get scleroderma-like skin changes, pigment alterations, sometimes ulcers due to microangiopathy.
Microangiopathy sounds like a surgical concern.
It is. It can be a contraindication to plastic surgery procedures. They also often have diabetes, cataracts, a high-pitched voice, baldness.
So surgically, the bottom line for these genetic conditions.
You really need caution. Avoid elective rejuvenation surgery in Ehlers-Danlos and progeria because of the significant wound healing problems.
But cutis laxa and PXE might be different.
Potentially. Rejuvenation surgery might be considered in selected cases of cutis laxa and pseudoxanthoma elasticum, since their primary issue isn't poor healing itself, but you have to weigh the specific skin quality and associated systemic risks.
Okay, let's recap the absolute must-knows. The 5 layers of the epidermis, remembering the top 2 are non-viable.
Definitely. Collagen as the key player for tensile strength, and that typical adult 4.1 ratio of type I to type 3 collagen.
The predictable histologic and physiologic changes with aging, thinner epidermis and dermis, slower turnover, reduced function across the board.
Right. And knowing which congenital disorders might be candidates for rejuvenation surgery, cutis laxa and PXE, versus those where it's generally ill-advised due to healing, like EDS and progeria.
So a final thought for everyone listening, especially those prepping for exams or early in their careers. How does this detailed knowledge, the layers, the cells, the collagen ratios, the aging process, really change how you plan and execute a plastic surgery procedure?
And building on that, what specific precautions or modifications might you need when operating on someone with, say, PXE or suspected EDS, even if it's for something seemingly unrelated? Thinking through these fundamentals makes all the difference in patient outcomes.